Hi, I'm Amanda Berra. I'm a research leader with Advisory Board. I've been with that organization for almost 18 years. So for those not familiar, Advisory Board does kind of best practice, what are common problems, what are common solutions type research, mostly for hospitals and health systems. And that's the area where I have concentrated my work. I work with sort of the general strategy group, so what's happening in the market broadly. And then I also like the business case for quality, how to line up the strategy case for doing what a lot of providers want to do in terms of mission. So that's been my area of focus. Right now at Advisory Board, we're busy throwing the book out the window, both in terms of research, right? We're coming up with all new answers as fast as possible. And also just the business model needs to change. Going to big meetings is not really a thing right now. Traveling to talk with hospitals and health systems also not a thing right now. So we're reinventing. Healthcare hero-wise, awesome question. I would have to shout out sort of a category of people, which is if you look at, specific to health systems, the executives who work there, some of them have made really different choices compared to the norm, especially when it comes to things like, of course, everybody's working to protect staff, but some of them have really gone above and beyond, and not just in terms of like physical safety, but also you see organizations like, Vanderbilt University Medical Center comes to mind as someone who really went all out from the beginning, making sure that staff that were idled could be retrained and put into new, different kinds of jobs. Mount Sinai just launched a big resiliency center for clinicians to think about like emotional recovery. St. Luke's in Idaho having a weekly web conference for all staff to just make sure they all know what's going on. Those kinds of actions, those you don't have to act that way, and some people just don't think of it or their priorities are elsewhere. But I want to call out the executive teams that have done that for their staff.
Thanks, Amanda. And just by the way, I was rightly called out for too much chit chat. So maybe you guys can help me by going a little quicker on the intro so we can get to the content. I'm just watching the chat. I probably shouldn't, but it's fair. Go ahead, Darryl.
Hey, good morning, everybody. My name's Darryl Jew. I'm a Senior Managing Director with Accenture. Glad to be here today. I've spent a lot of time in the healthcare consulting, have led our U.S. payer practice, as well as health and public service in the West the last few years. And currently my new responsibility is helping work with clients that are moving into healthcare. So health convergence is kind of the way we categorize it at Accenture. So it's working with clients that are trying to enter health, and I kind of bring the payer and provider perspective to help them understand how to work with them. I'm excited to be here, and my health hero is actually more close to home. It's my sister, Rita, who's a clinical pharmacist at UCLA. And even though we're sheltered in, she lives down in Orange County and drives every day up to UCLA. And I actually, she has 3 kids at home as well, but she's actually going there. And they used to have a van pool, but they don't have that now because a lot of people are sheltered in. And I try to call her every day as she's driving home just to see how it's going. I learn a lot because of what they're doing, but she's out there making sure and trying to figure out kind of how to deliver drugs to the right units, and also dealing with a census that is at 50% capacity and trying to figure out what to do. So I learn from her and watch her do this every day. So nice to see you guys.
Thank you, Darryl. Pete?
Hey everybody, Pete Masloski. I'm a principal at ZS, based out of Chicago area. I've been with ZS for over 23 years. And most of my career at ZS I've spent helping companies who have products or services or solutions that they're trying to sell or market into the healthcare industry. And most of what I've focused on is helping them market or sell their solutions, bring those solutions to market, and then drive revenues and profits based on those. So that's been my career. Today, I currently lead our firm's digital and connected health practice, so focusing mostly on the organizations that are really targeted towards increasing the adoption of digital within healthcare. If I had to pick one healthcare hero of mine in this whole crisis, the one person that kind of stands out above others in my mind is Dr. Li Wenliang, who is the physician in Wuhan, who was kind of the very first to really raise the red flag that this is a global health crisis about to emerge. Took tremendous personal risk to do that, and ultimately paid with his life to do that. So hard to imagine someone more worthy of such a status. Excited to be here.
That's a powerful one and very true. There was one quick question I saw in the chat about Amanda's role. A little backstory. Amanda and I worked together for about 15 years. So I can tell you that she leads research and actually working directly with health systems around those topical areas that she had mentioned in her intro. So I'm going to get right into the questions and move us along. Start with an easy one. With the breadth and depth of change that the pandemic is causing, it's tough to know what kind of moment this is for healthcare. What do you see the next 2 to 3 years being? A moment of pivot, slight pivot from the norm, a moment of evolution where we slowly kind of moved in the direction that we've very quickly been moving right now, or revolution. A lot of what is happening now with virtual care, a lot of what's happening to really keep clinical trials running, the innovations are just going to hit us immediately and change healthcare as we see it. Pete, maybe I'll start with you since you got to go last on intros.
Yeah, sure. Thanks, Tom. I think what we're seeing right now is kind of a leap. What I think is going to be followed by a pivot in a completely digital forward direction within healthcare. What I mean by that is the leap right now is, we've got this COVID-19 asteroid, which has crashed into the surface of the Earth and creating this huge disruption within our healthcare system, really affecting every corner, not only of healthcare, but of our lives. And that asteroid crashing into the healthcare system is going to have ripple effects that extend kind of well beyond the immediate crisis that we're in through this sort of 2-year period until we get to herd immunity or widely available vaccine and even beyond. And some of the effects that we can imagine seeing, obviously, healthcare providers in the center of this storm, having to completely retool their operations to handle the influx of the COVID-19 patients, dealing with the postponement of procedures, and having to kind of begin to reabsorb those procedures in a certain logical way, is going to create tremendous disruption for their operations and financial disruption to them. As a matter of fact, the AHA estimates that this could cost hospitals and systems as much as $200 billion dealing with this crisis. Not to mention the bill that'll come due for the vaccines and the treatments to treat the disease. So the financial implications are going to be quite significant, and they're going to create a bill which is going to come due ultimately to the taxpayer and to the individual. And so that'll be a lasting effect that will create some significant cost sensitivity in our healthcare system, even more than what we are experiencing on an ongoing basis. So that jump and those ripple effects will have a long-term effect. But we're also seeing this sort of pivot that'll turn into more of a revolution in things like virtual care and telemedicine. The rush to just try to implement telemedicine technologies and virtual tools to just keep the lights on and to keep care going is creating some lasting change in that habits and behaviors and expectations are being shaped and informed by this experience, right? How many that have had a seamless telemedicine experience with their physician in this crisis period will be accepting and willing to drive 45 minutes to a doctor's office, spend a half an hour in a crowded waiting room just to see their doctor for 5 minutes again? I think we're seeing a fundamental shift, and we will see a fundamental shift in some of these expectations and behaviors, which will have a lasting effect. And research that ZS has done with physicians really reinforces that. I mean, over half of the physicians we've surveyed really see telemedicine having a lasting effect. We also, in research with payers, see that they, for the most part, also see not winding back, many of the reimbursement changes that have been made to support telemedicine. So I think we're on a new trajectory. We've kind of leapt into this new direction, and I think it'll have lasting impact for the healthcare system.
Thanks, Pete. Pete mentioned the financial challenges that you made a specific reference to the financial challenges of hospitals and health systems. Amanda, same question to you, just knowing how close you are to those organizations.
I think at this point, I attach to, of the three choices, evolution, and specifically the idea that it's going to be a painful evolution, because there are some organizations right now that are better positioned than others to make the leaps that everybody's being asked to make at once. If you envision evolution as more like a staircase with a giant step up right now, I think that's what we're seeing. Some organizations that were already kind of digital first and that also had a sort of population management approach that was designed to keep people out of the hospital or treat them at home, those organizations have been able to pivot relatively smoothly, but your standard, big community health system has a long way to go to make those same kinds of changes. I think eventually the industry is going to get there, but some are facing a more painful gap than others. And that's definitely true on the financial side as well, right? The financial impact for hospitals and health systems is really different depending on what kind of organization you're talking about. Some of the big systems had a lot of cash on hand and have a lot of reserves. And the smaller organizations, more rural hospitals and so forth, are going to take a really hard hit. Did that answer your question?
Yes.
I hope so.
Yeah. Great. Yeah. Darryl, want to hear the same your thoughts on the same question.
Yeah, I think it's for me it's an evolution, and partially because I feel like it's unclear, and I'll give you guys kind of what I'm talking to a lot of payers and providers. I think the American public, how they're going to come back, and it depends on different parts of the United States. I think you'll start to see folks that still want to go see their primary care physician, and that's their mindset. And I see a lot of that in some of the providers. They're like, I think we're after shelter in, let's figure it out. I think there's also parts of America where virtual care is very much what I think the new norm, where people are like, hey, I'm fearful of going in. And I think it's going to be, based on the demographic space of the United States, is going to be different. The uptake is different. My whole thing that I've been talking to all of our leadership about is it's time to go talk to payers and providers. I think thematically people believe virtual care is going to be a pivot point and there's going to be adoption. But you have to understand, I've been pushing our partners to go out to talk to providers, to reach out to the payers that they feel have great relationships now, to proactively build relationships and agreements for service. I have payers that are willing to prepay providers, but instead of just prepaying, let's talk about the right contracted rate for virtual care. Mm-hmm. And so get the specialists that are not working at all, because dermatology is not essential, but there's a lot of pent-up demand. And so the idea of payers proactively working with their best providers and getting to a point where they could collaborate on how to reimburse for virtual care is an example of, I feel like it's an evolution. It's not like, hey, everybody's going to jump to that, because I think some of the providers are like, no, I want to wait to see if they're going to come back to my office. And so there's a lot of other things that I think, what is the American public expecting? I think during these times, we are starting to figure out what's really important. What do we really need to be treated on? There's a kind of a flip to that. There's a worry that some key primary care things are going to be missed. Vaccinations and kind of wellness kind of care. And how do we make sure people are doing it and not just sort of leaning on a virtual care visit saying, I guess I'm okay. So I do think it's an evolution, because I feel like, and depending on where you are in the US, I think people have a different kind of absorption. So I don't know if that's kind of my perspective, and having good dialogue with payers and providers to help them collaborate will help push the evolution of where this is going to go.
Thank you. It's never an easy thing to kind of put a label on anything, but all of your comments are kind of spot on from my perspective. now I'm going to ask you to pull the crystal ball in a little bit and maybe build on something, Darryl, you mentioned, at least in the subsonic, which is, now what are the next 12 to 18 months going to look like? And in particular, what are the services that you want to see entrepreneurs or legacy players stand up that just are not in existence today? Maybe Darryl, since you mentioned something about it, I'll give you a chance to talk a little bit more.
Sure. I think the thing that I've been thinking about, and I think we all know about it, but I think there's a way to build a more efficient testing capability. Because actually, my thought process was, it's not even just when you need a test and go to a health facility, but as we go back to work, I think employers are going to figure out, the ones especially where they want people to come into the facility or need to, how do you implement a process where you can, during these next couple of years, have a testing capability? And I think there's entrepreneurs out there trying to figure out the supply chain and the process to do self-testing. And so employers are going to use that as a way to make sure their employees are safe, as well as some semblance of contact tracing. We've started to see kind of Apple and Google talk about kind of providing the infrastructure, but then it could be stood up more by each employer. So those are things that I'm thinking about, that I think it will be a new normal. And I think having that, and then you saying, I'm going to come back into my massive call center operations or facility, or even a manufacturing plant, you're going to have those processes in there. And I think there's going to be entrepreneurs that are looking at that and how to package that efficiently. I'm talking to some of the pharmaceutical and life science partners who are my peers, and asking me to come in and talk about that while they're trying to figure out how to get that product to the market. So,
thanks, Darryl. Pete, what are your thoughts, and in particular, kind of what are those services you would like to see stood up quickly?
I think the next 12 to 18 months, we're going to be in this kind of strange, uncertain limbo time period where we're out of the immediate crisis, but we haven't reached this herd immunity, or vaccines and treatments aren't kind of widely available. And so it's not business as usual, it's kind of business unusual, if you will. And we're going to be in this mode of reacting to regional flare-ups and issues that pop up in different parts of the country. And we're going to need to have an economy, and companies are going to need to be able to identify and react and evolve very quickly on a very regional level to be able to kind of adapt their organizations to be able to deal with these flare-ups and changes as they progress over this time period. So, this sort of more nimble, agile model is going to require a certain level of intelligence, sort of an intelligence engine, if you will, to really be able to understand at a granular level, what are the trends showing at a very specific regional level? What does it mean for their particular business? How should they evolve? How should they get out in front of those issues to be able to compete in this environment? So, any type of sort of regional intelligence solution, I think would be really, and then how that would then translate into a specific company's operations and how they should react, I think will be a significant opportunity. And I also, so that's sort of one key area. I think another one, and building a little bit on Darryl's point about how do you build a testing capability, or how do you enable people to get back into the workforce, or even some events, right, that we hope to be able to attend, like conferences or shows or sporting events. Will there be a need to prove that you have either been vaccinated, or that you have a positive antibody test or a negative COVID test as a condition for participation, whether in certain jobs or activities, and will there need to be some type of a technology and capability that is well standardized and recognized to be able to support that?
Amanda, how about you? Again, I'm interested in kind of 12 to 18 months, and what services do we need yesterday?
Yeah, we have such a long wish list going, but definitely top of my list would be things to basically reinvent post-acute and nursing home settings to make them, more digital, to enable people to visit, their loved ones who are right now sequestered away. A lot of architecture changes generally, like we're getting a lot of questions and a lot of interest on sort of the hospital and health system side, as well as a lot of, new ideas on the architecture and infrastructure, like vendor community, about how you could just rework physical spaces to make it more practical to see patients when they do have to come in person. And then, just to kind of take a different angle on your question a little bit, I mean, I know there needs to be a lot of new technology and, new services stood up, but from my perspective, I mean, there are cool things that exist in the system somewhere. But when I think about, kind of the national delivery system as a whole, a big part of the challenge is going to make sure that it exists everywhere so that every patient who is trying to access services can access them, as opposed to like a really awesome at-home testing / digital solution that only exists in a metro area, right? What about rural areas? I saw in the chat, people are talking about the fact that there's a lot of places with no broadband, right? There's going to be a ton of, innovation and imperatives there to stand things up, fix holes, and, make the whole thing a little bit more cohesive.
Mm-hmm. Let's get a little bit of audience involvement, because I keep looking at the chat and keep wanting to change my questions, but I'm told that's a B actor thing to do. Let's talk about providers for a moment. Elaine, can you activate the second poll question? So the question I have is, do you believe that loosened regulations for interstate physician licensure and telemedicine visits reimbursed at the same rate as in-person visits will outlast this pandemic? And just to make it simple, we made it binary. No maybes here.
I'll give it a couple more seconds and then I'll share the results.
Sure.
I already want to argue with your binary setup. Which
I'm
ones?
just trying to make life
Which
difficult.
regulations? Okay.
I think those are two things in there too. The licensure versus the reimbursement are completely different to me, a little, so. But that's okay. No criticism.
Wow.
Wow.
Actually, I actually did say yes, but I'm surprised by the data here. 66% believe that we are not going to have kind of a guild-like rollback, which frankly I think is it's unlikely that we aren't going to see a lot of pushback. But I really hope that we do kind of stand our ground. Put the question to this audience. Darryl, what do you think? And why don't you answer the question the way you think it should have been asked?
I would have broken apart the licensure cross-state. I definitely think that should actually stay, and the flexibility. I think that's an easy yes. I think on the reimbursement, if you're a pure capitalist and you believe that over time the right service for the right amount will work itself out, you would say yes to that too. But I think that's right now the transparency of who pays for healthcare and how much it is. That's where it's a shock factor. Because right when you look at, I'll give you guys one example. For a very high-end dermatology visit, some dermatologists cost $300 to $350. And for a visit virtually, I don't see that being the right rate across the United States that people are willing to pay. In fact, they don't get reimbursed at $350. For the negotiated rate, they probably get 60% of that. And so in my mind, to really break away the noise, because I'm going to value it at $350, but I get reimbursed at $175. The virtual visit, if you said, let's do it at $175 and everybody stays whole, then that's good. But if the market starts by the doctor saying it's $350 the demand won't be there. So I don't know. As I'm working through this, trying to get people to recognize both the physician side to understand what you actually get reimbursed versus what you believe you explain to the payer than what actually happens. There's a lot of noise in the system. So.
Okay, thank you. Amanda, why don't you take that question and we'll give Pete the chance to finish off.
Well, I mean, I think generally speaking, deregulation in telemedicine, I mean, I think directionally, I agree with the audience. I think that most of those measures are here to stay, you know, in aggregate, right? Well, some of them will be a fight. It's not going to be easy to get to a world where telemedicine, you know, reimbursement and licensure is as permissive as it is today. But I think it's hard to fight the forces of efficiency, especially given, you know, how, you know, again, from a delivery system perspective, you have a lot of systems that are, you know, regional, multi-state, if not national. I mean, healthcare delivery is just kind of going that way. I can also see a world in which you have labor shortages for certain kinds of jobs that require, you know, doing more telemedicine just to meet the needs of patients. So I don't know how, and I think it will be messy, but I think directionally speaking, many of those deregulation steps will stick around.
Thank you. Pete, what are your thoughts?
Yeah, I'm an enthusiastic yes about the future of telemedicine here. And I think I like the way Darryl kind of broke it out between the interstate licensure issue and the reimbursement issue. I think those are different. I think the interstate should be an easy one. Hopefully that one sticks without too much trouble. I do think that there will be circumstances where it does make sense for a telemedicine visit to be reimbursed at the same levels as an in-person visit, and you'll see those examples. But I also think there'll be this big debate, especially in the context of the cost pressures that really emerge and are amplified as a result of this crisis that come down. And I think, you know, there'll be a little bit of a hesitation and worry that telemedicine will increase utilization as opposed to lead to inefficiency, because if you look at, you know, some of the early studies of the impact of telemedicine, it hasn't actually saved money. It's actually increased utilization. So I think there'll be some concerns on that dimension that actually sort of drive down reimbursement rates, and some restrictions will work their way back in. But by and large, I think we're going to see a much more telemedicine-friendly reimbursement environment than not.
Thank you. I want to ask a slightly different question, and it has to do with equity in healthcare, especially amidst the pandemic. I think it's fair to say that disadvantaged populations entered this pandemic in difficult circumstances and are suffering disproportionately today. The data points in that direction and that direction only. What is your most optimistic take on how the current situation can catalyze change for communities of color, the aged in nursing homes, the medically frail or disabled, and now the uninsured, which are up probably 30 million easy? You know, what's your optimistic view on this? And Pete, maybe we'll start with you this time.
Sure. If I take the view of, you know, looking forward towards the point where we're going to get out of this crisis, right? Where what's going to get us out of this is a widely available vaccine or treatment options that are widely available and accessible. The most optimistic view would be that these solutions are made readily available, and that the allocation is done in a way that's maybe driven centrally. So for example, instead of the pure market-based allocation of vaccine driven just by demand and normal supply-demand forces, that there's a process where those who need this vaccine the most get the vaccine first, right? And so that would be high-risk populations. It would be employees or people who are on the front lines treating patients in this situation, and that there's a risk-based, if you will, distribution. Of course, the opposite of that would be if there was more of a privilege-based or a who can pay based system for how these treatments and vaccines ultimately get distributed. And I think, going back to also what's going to happen from a payer perspective as we emerge through this crisis, we're obviously going to see a larger number of uninsured emerge at the back end of this, and more covered lives will move from commercial based on the unemployment to Medicare and Medicaid. And so the most optimistic view, again, would be that policy ends up ensuring that those populations get the care that they need and are supported and taken care of through this crisis, as opposed to budgets being cut. And you're even seeing some debate right now about state Medicaid potentially being cut in certain states. And I think there'll be a big debate on how to pay for all this. Again, the most optimistic is that it's the care of the people who are most at risk that gets priority. But of course, the debate will be where that ultimately lands.
Yeah. Darryl, what are your thoughts? Keep them optimistic.
Okay. I think first I would break it down into kind of three categories. First, sort of like the access to vaccination, or as we get other issues that kind of raise up, I'm very optimistic that the American public and our government are trying to figure out how to get people the access to that care. And I do think we're getting, we're seeing a lot of energy to kind of solve that. And I think that's table stakes. That will happen. The next one, which is more the next generation, and this is really giving people, majority of Americans, just access to primary care and urgent care. And what you guys have started to see in the industry is that there's companies, this is kind of where I was going with Convergence, trying to offer up primary care access at very affordable prices. Walmart is targeting the rural areas. Amazon is targeting kind of virtual care. And what that's going to do is make access for 80% of Americans who just need good primary care and urgent care available and accessible. So I kind of feel like that's already got, and when I talk to payers and providers, they get nervous because that's commoditizing the front end of where the high volume is. And then where I don't have the optimistic view yet, or I don't know exactly the school solution, is chronic illness, where people are consuming a lot of services. Some of it can be virtual. There's new digital health products that actually help people manage their care and drive down costs, but sometimes it's hard for physicians to actually advocate for them because it reduces their fees, which is just like kind of contrary to logic, right? But there is a new balance, and we need to figure out how to push that forward. I think that's the part that I haven't figured out how it's going to end yet. But we definitely have new technologies that's reducing the cost and more proactive monitoring of chronic illness, both for long-term care for the aged and as well as people that have chronic diseases that they live for their lifetime. So I'm hopeful because the tech is there. And for me, it's never about the tech. It's about getting physicians and payers to collaborate and getting the citizens to say, I want that or I need that, and that's better. So that's kind of my perspective.
Technology is always the enabler, never the solo answer. Amanda, let's hear your take, and then I'm going to actually invite Elaine to start bringing in some questions from the audience.
Okay. Well, I'm happy to have a chance to answer this question because I'm a huge optimist, and I feel like it's important for us to start with the stance that some of these problems are solvable, just to give ourselves the energy to go after them. I have three on my list. One is, my hope is that the fact that you have this dramatic pandemic coming in all of a sudden and hitting, for example, the United States all at once, will show up some of the entrenched problems that we already had around, poverty and racism, like all of those kind of structural issues. It's going to be really hard to ignore that different populations have really different outcomes. So my hope is that, we light a fire for some policy solutions there. A second one is, my hope is, and I kind of mentioned this a little bit earlier, that the whole post-acute delivery system gets a rethink, right? Everything from how it's reimbursed to, how those facilities are staffed, right? The labor issues and the intense turnover that you have in post-acute and nursing homes, et cetera. The fact that it isn't very kind of technologically advanced. My hope is that gets a second look. And then last is actually coming back to, Darryl, you were talking about access to primary care for everybody and the fact that, you get some patient populations, especially the chronically ill, that aren't totally, well served by that type of model. I actually think you could see a lot of proof behind emerging models for segmented primary care for like chronically ill populations. I mean, we were already seeing a bunch of those models pop out, like the ChenMeds of the world, the Ioras, the Oak Streets, that are focused on patients that have chronic conditions. My understanding is that those people are pivoting pretty well in the current pandemic, and I wonder if there's not some lessons that we can learn and imitate as an industry to try to serve people who have those kinds of needs better from a primary care and management perspective. That's my hope.
Yeah, and one organization that if you all are not aware of, that's doing a lot of work in this space is Health Tech for Medicaid, and I think what the issues that they're raising are not just policy issues; they're practical issues for addressing these challenges. Elaine, can we get to the good stuff now? The Q&A.
Yeah.
From the audience.
Thank you everyone so much for submitting your questions. We got a whole bunch of questions, so I apologize if we don't get to all of yours today, but we will share, if you stick around for the end of the webinar, we will be sharing everyone's contact information, so feel free to email everyone separately then if we don't get to your question. Okay, so the first question I have is addressed kind of to all panelists. Tom, I'll let you redirect the question. It's, are organizations dropping out of or pulling back on ECOs/value-based care? If so, what kinds, and what shorter term and longer term impact is COVID likely to have on accountable care?
Let's start with Amanda on this one, and
sure.
I know you're close to that.
We've been talking a lot about this with a lot of providers, and also looking at what CMS is doing. I mean, I think in the short version is that, of course, there's a ton of anxiety about what does all of this mean for any providers that have kind of like a hefty amount of risk, accountability for total population cost. And I think, any amount of uncertainty makes people nervous. However, the word so far is that the organizations that have committed to move on a journey toward more population health are still pretty committed to doing that. And for their part, when you look at what CMS is doing, it seems like CMS is being, pretty reasonable in terms of saying, hey, we're not going to hold you accountable for costs that, you couldn't possibly have foreseen and that you couldn't do anything about because it's hard to get out and, treat people right now. My general feeling from listening to those conversations is that, while of course there's a lot of uncertainty, people who are committed to taking on population risk are still committed to it. And it's just a question of figuring out, a safe path that makes sure they're still financially sustainable.
Great. Peter, Darryl, do you want to take this one? I want to get to as many questions as possible, so I'm not going to force everybody to answer each of these.
No, well, my only perspective is I don't think it changes the need and desire to move to more value-based care, and I think that's the right answer. And I think it adds a new variable about how to look at virtual care. I think that people are going to start to understand maybe the different kinds of consumption models as well. So I do think that we still need to altruistically move there, and I think it could even go back to starting at self-insured employers. We're starting to see they tend to have more of a stake in the game to helping take on that risk and understanding how to curate the right services. So that's another way to think about it.
That's great. I think we're going to go to the next question. One thing I do want to ask is if we can put the link to the survey, re-up that in the chat. I'm sure people are going to need to drop off in stages. Really important to us to get feedback on the quality of what is the first of a series of virtual events. So would really appreciate that input. And we will send the recording to folks who are able to fill that out. What's the next question, Elaine?
So the next question is again addressed to all panelists. How will the quality of healthcare provided be measured now that the world has shifted to a virtual environment? Additionally, how will the measurement of health status be changed now that the world has shifted to a virtual environment?
Pete, can you tackle that? I know, especially some of your work in diagnostics has got a kind of, you must have some opinions here.
From a how do we measure things perspective, if I take a broad view, I think the exciting thing is that this crisis should be accelerating the usage and adoption of technologies that enable us to capture a much greater picture of the entire patient experience, right? And so we're not just talking about certain lab tests that correspond to certain patient visits once in a great while, right? And the promise of digital health is that it illuminates a lot of the whole journey that a patient has within their disease, right? And so what I would love to see come from this crisis with the greater adoption of digital technologies is that we get a much better appreciation for the sort of blind part of healthcare, which is what happens, during the 99% of time a patient is not in the physician office, right? When they're living their life, and that the pervasiveness of these technologies becomes such that we begin to identify, not just the lagging indicators of health that show up in lab tests and when patients show up in the emergency room and we have adverse events and so on, that we start to see leading indicators. And we start to identify ways to intervene based on those leading indicators and change the curve that we're really trying to bend in this situation. So, broadly speaking, I hope that we move in that direction, and that we start to think more in a preventive and an interventional mindset as opposed to more of a reactionary mindset.
That's great. Amanda, Darryl, do you have anything you want to add, or move to next question? Tacit approval.
Tacit approval.
Let's get another question in there.
Sounds good. Okay, so with the growing concept of contact tracing and passive sharing of health information, do you think this will hinder or accelerate the concept of patients as their own data steward?
That's a great question. Darryl, why don't you tackle that first? And
yeah,
I'd love to hear Amanda too.
Yeah, my hopes are it actually opens, I think it's always been up to the American public to be comfortable with it. I think the need to kind of be aware of where the disease is and, their own personal certifications. I think we have to get comfortable with it. When we get comfortable, it allows us to have that data kind of be more pervasive. It's going to be interesting. I think I still think it depends on where you are in the United States. Some people are more comfortable and less comfortable. I think the new millennials are much more comfortable with that data and me owning that data. I think there's new regulations that make sure that payers and providers are not blocking access to the data, at least in the de-identified way. So I do think that's the right trend. So I do think it's a trend that I think is going to happen over time. So that's my perspective.
I mean, I think I would largely agree. I'm picking up on what you're saying about how it depends who. I mean, there's a certain share of the population that is able to kind of make that leap if they, understand why and are given the tools. And, this crisis will cause that part of the population to do that. But there's still a huge part of the population that is not well positioned to grapple with it as an issue or technologically or for whatever reason. And those people, are going to need protections coming from elsewhere.
Right. What do you think, Pete?
Yeah, just to jump in, I think this is going to represent a pendulum shift similar to, what we saw after 9/11, when there was a pendulum shift from, privacy and security of your own data to data access for the public good. And I think for many reasons that's the right direction. What's likely going to happen is that pendulum will probably shift too far, and there'll be a debate that once things settle down, we're past the immediacy of the pandemic, that debate will emerge, and we'll settle back into a harmonization of the appropriate amount of protection and privacy, and the balance between public health and individual data privacy. And we're seeing some of this debate happening right now, as a matter of fact, between states who, from a contract tracing perspective, would love to be able to get GPS data on exactly where people have been, whereas Apple and Google have been very clear that they'll show the Bluetooth connections, but they are not allowing a GPS trackers to go along with that. So we're already seeing some of that debate happen right now.
I mean, I feel like there's a wild card here, which is how much and what kind of problems are going to crop up as a result of increased data sharing. And actually, this is coming back to the earlier part of the conversation about deregulation for telemedicine. Same thing again, right? How much fraud and abuse is a question that what are we going to see problems, fraud and abuse, or people's privacy being trampled on? How much, what kind, how much severity of that type of problem? That would be, a big game changer in terms of whether you can allow more liberal use of information sharing, more liberal, licensure, all of those types of things that we want to have. But it's like can we have nice things or not? We will see.
Yeah, I think just to add my voice on this one, I don't think we can move quickly enough on freeing the data, because data is not information. It's going to take time to really empower people like me to be able to use data and even shape it into actionable information that I can take from physician to physician, from practice to practice, during episodes of care or over time. I'm going to keep being optimistic, but we need to go because we have a lot of work to do. I hate to do this, but we are going to have to pull up on this conversation. I think, Pete, Amanda, Darryl, thank you so much for this dialogue. I would ask everyone who's on the call, and I apologize for not getting to all of your questions. We have on this slide the email and contact information for each of today's panelists. Please reach out, ask any questions that you that didn't get addressed, and also that you have and just come to you after the fact. So I'll leave you with a question to take back to your teams. Are you steering back to the legacy world? Are you thinking about and challenging yourself around stewardship of the business that you're operating today, or the service you're operating today, the practice you're operating today? Or are you steering a course to take control of uncertainty and act with an innovator's agenda and be a catalyst for change? I think that's probably a really important question for all of us to ask and answer. And with that, I thank you for attending today. I look forward to future sessions. And most importantly, everyone stay well. Thank you for joining us.
Thank you, Tom.
Thanks for having us.
Have a great weekend.